are going to help us in terms of understanding the why we need the peritoneal dialysis, and very appropriate topic by Dr. Irfan Munir. Why not peritoneal dialysis? And we have seen that in many countries, in Hong Kong, Thailand, they're going almost 50 or more than 50% initial start with the peritoneal dialysis, and this is something they have realized for the benefit of the patients and for the economy at the larger scale for the country. And we being a nation who requires to be cost effective, so we need a lot of input in these suggestions and way forward. Similarly, we have Dr. Kiran from Shifa International Hospital. She is a very enthusiastic nephrologist for the peritoneal dialysis, and she is the one who, along with the other team members at Shifa, has made sure that the northern part of Pakistan is covered with peritoneal dialysis, and very well so. And they have a large number of patients that they are following over there. We have Dr. Mudassar Murtaza Chima. He is head of nephrology at Rawalpindi Institute of Urology Transplant. He is again a very keen enthusiast in peritoneal dialysis, and takes part in our peritoneal dialysis webinars and workshops. And he is intending to initiate peritoneal dialysis soon at his center, with all the logistic issues that we have currently facing in Pakistan. I think that will be overcome very soon with future things coming in pipeline, inshallah. Dr. Ahad Qiyum, Peritoneal Dialysis Pakistan Academy, is the president. Unfortunately, he will not be here because of some commitment that came up, and she apologized. But we have Dr. Azhar Wahid, Dr. Mohsen is going to join us soon, and we'll have a good session, inshallah, today. So let's not wait you guys further, and well, let's start with Dr. Irfan Munir. Sir, please. Rasib zara isko aap wo slide PowerPoint slide show mein.
Shukriya ji. Assalamu alaikum ji. Thanks, Dr. Nov'23, for a very candid and kind introduction. Just you just put everything in a nutshell in terms of where we are, partly in terms of global perspective and where we need to head on. A few words about myself. I'm a graduate of King Edward Medical University, 1987, and I trained in Connecticut at Yale School of Medicine, and then I did my nephrology at Medical University of South Carolina in Charleston. I've been in clinical practice since 1999 in Indiana, and I'm on the faculty at Indiana University Medical School. I also run a very active private practice, and since start of my practice days, home dialysis, both peritoneal dialysis and home hemodialysis had been my niche area. So as you can see that my topic of my talk explain what our discussion will be tonight, that with a historical perspective, in my own experience, when I got into practice in 1999, in United States, the prevalence of peritoneal dialysis was about 4% in all the patients who had end-stage kidney disease, and 95% or so of patients were being dialyzed by in-center hemodialysis. Over the last 23 years, that has changed just a little bit. At this point, when we look at the landscape in the United States, about 10% patients are on peritoneal dialysis. Still about 90% of patients are being dialyzed with in-center hemodialysis. Next slide, please. So why shouldn't we choose peritoneal dialysis for our patient? I mean, certainly it provide a tremendous benefit of quality of life, as well as providing patient autonomy and flexibility to be able to dialyze themselves at home. In addition to that, the patients do not have to take care of logistics things like transporting back and forth to the dialysis unit 3 times a week, have to go through like 2 needle sticks or 6 needle sticks a week, uh, and plus with additional benefit of peritoneal dialysis, that those patients who tend to get treated with peritoneal dialysis uh, have retained their residual kidney function longer than in-center hemodialysis. And as we all know that residual renal function is the single most important predictor of survival in end-stage kidney disease patient. So preserving uh, residual renal function in people who have started dialysis is very important for us. Uh, in addition to that, I mean, in the market of the United States, there's a tremendous cost economic benefit of doing peritoneal dialysis. At this point, the per year cost of providing patient with peritoneal dialysis is about 30% less than in-center hemodialysis. Uh, Next slide, please. Next slide, please. Next slide. Can you please move the slide, please? So, despite benefits of peritoneal dialysis, why there's still some why the growth is so limited, not only in the United States as well as in the other parts of the world as well. Certainly, if you want to start on a peritoneal dialysis program, it requires more upfront work. The most important thing for initiating a peritoneal dialysis is creating a good infrastructure, that is training the paramedical staff well, uh, so they in turn can train the patients. And certainly when you start somebody on peritoneal dialysis, uh, you have to train the patient. Not only that, you have to train the patient, you also have to devise a prescription which is not only going to provide them good dialysis, but a prescription which is suiting their daily routine and lifestyle. Uh, Whereas starting somebody on hemodialysis is very easy. I mean, it just takes 2 phone calls, one call to get the line placed, and second call to the dialysis unit to get a chair and giving dialysis orders and get them started on hemodialysis. An additional factor which I've come across in my clinical practice is that the comfort level of the nephrology trainee and nephrology graduates with peritoneal dialysis. When I went through my fellowship, there was very little exposure to understanding and training of peritoneal dialysis. And most of the training and learning which I acquired for peritoneal dialysis is through my clinical practice. And same way as I've come across and worked with many nephrology trainees in Pakistan, as well as graduates from a nephrology training program, their exposure as well as their level of training in peritoneal dialysis is lacking. So they do not come out of their training program adequately trained in peritoneal dialysis. So certainly starting peritoneal dialysis, especially when you don't have infrastructure and established program, it'll require a lot of upfront work. And number two, the comfort level of the nephrologists who are in practice is lacking in Pakistan. Next slide, please. So this is the incidence of end-stage kidney disease in the United States. Presently, there are about 750,000 patients on renal replacement therapy, and the per year incidence is about 120,000 new patients per year. Next slide, please. So as you can see that projected prevalence of end-stage kidney disease in the United States in year 2030, we expect to have over million patient, over 1 million patient with end-stage kidney disease uh, on various form of treatment by year 2030. As you can see that the prevalence of all the risk factors which lead to end-stage kidney disease, including hypertension, diabetes, obesity, is increasing. As you see that with increasing prevalence of all these risk factors and increasing life expectancy, we're expected to have increased prevalence of end-stage kidney disease. And then the same holds true for Pakistan as well. I think at this point, a rough estimate is there are about 500,000 patients of end-stage kidney disease in Pakistan. About 10,000 to 15,000 patients are on various modalities of treatment, out of which approximately 100 or 120 patients are on peritoneal dialysis. But still, the main form of treatment in Pakistan for end-stage kidney disease is hemodialysis. Next slide, please. So when you can see that this slide shows you that the excess uh, at the time of starting dialysis in end-stage kidney disease and then 2 years down the road. At this point, the KDOQI guidelines require for starting somebody optimally on end-stage kidney disease treatment, we need to either initiate the treatment with the AV fistula or start them on one of the modalities of home dialysis. The use of central line for starting dialysis is discouraged because it's associated with increased mortality. And when you look at like 2-year relative risk of death in patients who are starting dialysis with a permacath as compared to those people who are starting dialysis with AV fistula is about 2. So the relative risk of mortality of 2 at 2 years out of those people who are starting dialysis with the permacath. Next slide, please. Again, to reinforce the same point that the mortality of end-stage kidney disease patients is determined partly by the kind of vascular access they are being dialyzed. Next slide, please. If you can look at y-axis, there is survival, and on an x-axis, the time period, and the lower dashed line is the patients who are starting dialysis with central venous catheter. And the upper lines are those patients who are starting hemodialysis either with AV fistula or AV graft. And if you can see that the mortality or survival of those patients who are starting dialysis and who are being dialyzed with central venous catheter is less when compared to those patients who are starting dialysis either with the AV fistula or those patients who are starting dialysis with peritoneal dialysis. Next slide, please. And the reason of suboptimal start initiation of treatment in most of these patients are that we still in a very sophisticated medical environment, such as United States, the patients are being referred late to nephrologist. And despite the patients being seen by nephrologist, a lot of patients do not get educated how to optimally start a treatment once they progress to end-stage kidney disease. Next slide, please. So the reason the patients are starting suboptimally on end-stage kidney disease treatment is that sometimes there's a delay in the referrals. Sometimes we recommend a patient what is the right kind of treatment, but they do not want to go through that route. Sometimes that's acute worsening in kidney function, and we do not predict in advance that which patients are going to progress to end-stage kidney disease and need dialysis. And sometimes there's surgical delays. I mean, these are the factors which lead to some optimal initiation of treatment of end-stage kidney disease. So when I talk about suboptimal initiation of treatment of end-stage kidney disease, that typically would mean that those patients who progress to end-stage kidney disease and are starting treatment with a central venous catheter. They're not starting dialysis with a fistula, or they're not starting on home modalities like peritoneal dialysis or home hemodialysis. So at this point in United States, the CMS, which provide all the funding for dialysis, they have started to impose fiscal penalties to nephrology practices and hospitals who are not achieving a certain goal of starting patients optimally on the treatment. It is not that only their survival is better once they're starting optimally on one of the end-stage kidney disease replacement therapy. The cost and economic benefit is also substantial. Next slide, please. So that is a slide which in a nutshell tells you that the residual kidney function is one of the important predictor of outcome in end-stage kidney disease patient. Losing residual kidney function will lead to a lot of adverse biochemical as well as inflammatory consequences, which will lead to increased cardiovascular and overall mortality, and also decrease the subjective sense of well-being and quality of life. Next slide, please. As you can see in this slide that which shows you on the y-axis, it's the residual renal function. On the x-axis is time since initiation of treatment. You can see that even 4 year out, people who are on CAPD has some degree of kidney function, where all the patients who have been initiated on hemodialysis, it's lost all the residual kidney function by 4 year out. Why is that important? Next slide. This is a study which was done, which showed, next slide, please. Yeah, this study was very well done study, which in which the cohort, both the groups were very well matched. And those patients who started hemodialysis with central venous catheter were included from the final analysis. So this study looked at the outcome and survival in patients who were being treated with peritoneal dialysis compared to those who were being treated with hemodialysis. Next slide, please. So if you, on the y-axis is your survival, on the x-axis is the time. The solid line is the patients who are being dialyzed by peritoneal dialysis. The dashed line is the patients who are being dialyzed through hemodialysis, in-center hemodialysis. So the left graph is as treated, and the right graph shows you intent to treat analysis. And as you see in the first 3 years, there is a survival benefit in patients who are being dialyzed through peritoneal dialysis modality. And after that, the lines cross and match, and after at 9 or 10 years out, their survival was similar. So in the first year, this survival benefit of peritoneal dialysis can add substantial advantage to their well-being down the road. Next paragraph. So this is data from Dr. Ghaffari's group. Next paragraph. Next slide, please. Next slide, please. Just skip 2 more slides. So just stay here, please. So basically, this study came in around 2009. And what they showed is that this study came out from UCLA Medical Center, which is an inner city hospital, and they were seeing a lot of patients crashing in the emergency room with end-stage kidney disease without prior education on any planning for starting dialysis. They started this prospective study around 2009. They got published about 2012. And what they showed is that the patients who were crashing in the ER with the consequences of progressive kidney disease, were uremic, were volume overloaded, hyperkalemic, had different indications for initiation dialysis, and having no planning to start end-stage kidney disease treatment, did not have a maturing fistula. So they quickly educated the patient in the emergency room around different modalities of dialysis. They quickly screened the patient if the patient is optimum individual to be maintained on peritoneal dialysis. And they asked for patient consent, and those patients who consented had a peritoneal dialysis catheter placed. And then subsequently, they were started in dialysis within the next 2 to 3 days after placement of peritoneal dialysis. So with the, I mean, our group is doing urgent start peritoneal dialysis way before that. I think we started doing it in 2000. We never got published, but with this study, since it got published in one of the good journals, this wave of nephrologists starting to accept this way of approaching treatment of end-stage kidney disease, starting nephrologists started to accept that modality or that way of starting people on peritoneal dialysis more and more. And the reason I'm showing this slide to you is that when you look at this slide, this tells you what you need to look for when you are trying to see whether a particular individual would be a good candidate for peritoneal dialysis. First thing is obviously, I mean, are they physically able to carry 20 pounds? Did they have a lot of abdominal surgeries in the past? Do they have massive hernias like which would not be amenable to surgical treatment? Do they have a place they call home? Or do they have access to a clean bathroom and a toilet where they can wash their hands, and they have access to a sink or toilet where they can drain their effluent? Are they do they have good hearing? Do they have good vision? Do they have any pets at home? And if there were any pets, are the pets confined to a certain area, or they're free to go around in the home? And is their home clean? And if the home is not clean, could the environment be kept clean? And this is a checklist which we keep with us as well when we screen patients for peritoneal dialysis, especially when our staff does training. They use a similar checklist to look at it, whether any individual is going to be fit or good for peritoneal dialysis. And this is something which you can done in less than 1 minute at the bedside to decide whether somebody would be a good candidate for peritoneal dialysis. And when you look at the environment in Pakistan, most of the patients, like a majority of patients which you come across, do come from a lower income background where they don't have ability many times to do this kind of treatment at home. And the way we can tackle that in the environment of Pakistan is that I did start assisted in-center peritoneal dialysis program at Mayo Hospital. We screen and we follow the patients closely. So far, I think we discharged one patient to continue dialysis at home. But we felt that that patient had a good support staff and good circumstances and environment at home, that he can continue his treatment at home. Majority of patients which we are still dialyzing in the in-center program. When Dr. Nov'23 talked about Hong Kong and Thailand, especially in Hong Kong, there are in-center dialysis unit which are providing assisted in-center dialysis to a lot of patients. So that is a model which we are looking to promote in Pakistan moving forward, that we want to create a lot of assisted in-center peritoneal dialysis centers with few patients which will be dialyzing eventually at home once we are assured that we were not going to be faced with infections, compliance issues, and all that, those kind of things. So next slide, please. So certainly, I mean, when we see end-stage kidney disease, either they are presenting to us late or early. There are two ways in which they can be started on dialysis. One is hemodialysis, one is peritoneal dialysis, which can be done either urgently or non-urgently. Urgent start is those patients who start dialysis within 2 weeks of placement of peritoneal dialysis catheter. And the non-urgent starts are those patients who start dialysis after 2 weeks of placement of peritoneal dialysis catheter. Next slide, please. So this is what I'm going to sum up my talk with. Could temporary vascular access, such as central venous access to initiate people on dialysis be avoided? Could a catheter that is placed be used for the acute and chronic setting so that the only one procedure is required? Could we initiate a dialysis modality that may preserve residual kidney function? Could we recognize lifestyle concerns in the late referred patients or in any patient? So here I think I am making my point that certainly peritoneal dialysis is a dialysis modality which will help the patient uh, not to preserve their kidney function, but the lifestyle benefit as well. And moving forward, as we keep on working on development of infrastructure in Pakistan, we are very hopeful that the cost of peritoneal dialysis down the road would be substantially lower than hemodialysis. I'll stop there, and I think I'll turn it over to Dr. Noman Tarif.
Thank you very much. That was a very informative lecture. So almost like 120,000 new patients adding up in USA for dialysis, and that's a frightening number. And if you rightly said that, in Pakistan we don't know what is our actual numbers. We tried to develop some registry, but now PSN has taken up the lead again, and they are starting a new registry, which is going to take up all the patients' data. And so we'll have some idea probably in a year time that where do we stand at this point. But I think in what we have a registry from before with Professor Vakar Saab from Sheikh Zayed Hospital, we have like 5,000 documented patients on hemodialysis. And there are almost like maybe 20,000 or more patients who are undocumented. So I think it's a very frightening number, and we cannot keep all these patients in the hospitals. So we have to provide different ways, as you rightly said, home dialysis, home peritoneal dialysis, and maybe in-center peritoneal dialysis, all these things. So going to the next talk, I would like to invite Dr. Kiran from Shifa Hospital. And this is about the non-infectious complications of peritoneal dialysis. That is not to frighten everybody that there are so many complications with peritoneal dialysis. But, the reality is every modality has its some pros and cons. So, but we can get over with these complications if we understand. And as we have learned over the years with the help of our colleagues in Lahore and in Karachi and in Islamabad, what are the local issues and how we can overcome these. So over to you, Dr. Kiran, please.
Assalamu alaikum. So I'm going to share my screen. Can everyone hear me?
Yes, we can.
Yes, we can, please.
Okay. So right. Let me just start. Thank you, Dr. Naman, for your very detailed introduction of mine. So let me just tell you a little bit more about myself. I'm a graduate of Qaid-e-Azam Medical College, Bahawalpur, 2005. I did my internal medicine training at University of Pittsburgh in 2013, and after that, I did my training in nephrology at University of Pittsburgh in 2015. Since then, I've been working at Shifa International Hospital in Pakistan since 2015. And even though I was very enthusiastic, as you said, about putting people on peritoneal dialysis and starting home dialysis modality, including hemodialysis and peritoneal dialysis. It took me 2 years to convince my first patient to believe in me and start peritoneal dialysis. But since then, we've come a long way. Alhamdulillah, we have close to 100 patients now. and we have some children as well on peritoneal dialysis. Um, uh, and Today I'm going to talk about non-infectious complications. Um, this is a very broad topic. I'm going to highlight some of them and briefly touch upon the management of some of them. So, since infectious complications are downtrending in most of the Western world, the non-infectious complications are being recognized as a major reason for technique failure and being shifted onto hemodialysis permanently. So, according to one study that was published in JASN, 1 year catheter survival of 80% and primary non-function rate of less than 10% are acceptable. So, I think when we see that, it gives us hope that we're doing uh, very well in terms of our centers, which have a very small number and very few surgeons or nephrologists who are trained to put in catheters. And our 1 year catheter survival is almost 99%. There are multiple ways a PD catheter, tunnel PD catheter, can be put in. But the best way to do it is laparoscopically, because it has the benefit of um, adenolysis, making sure that the catheter is placed in the deep pelvis, and if there is any redundant omentum, it can also there can be omentopexy done. So there's a large list of complications, hernias, leaks, hydrothorax, hemoperitoneum, chylous peritoneum, bilious peritoneum, blockade of catheters by a number of reasons, having multiple kinds of pain because of being on peritoneal dialysis, EPS, metabolic syndrome, to name a few. So I'm going to talk about only a few of them. I'll start with the most simple one that we come across. Pain is a common symptom in patients. Back pain, lower back pain is something that comes with time, or many patients complain of it early on in the first 2 months. That is because of change in the center of gravity, because of having 2 to 3 liters in their belly, which they are not used to, stress on the muscles, and especially if the patients are malnourished, they have very poor muscle tone, and they complain of back pain. The treatment is to do smaller volumes of PD exchanges, putting them on APD, doing nocturnal PD, and also suggesting muscle toning exercises for abdominal muscles and paraspinal muscles. Then there is the infusion pain, which is usually in the early days of PD, and it dissipates over time. That's what I've seen. It's probably due to the acidic nature of the dialysate, and it goes away with adding bicarbonate to dialysate. Another thing I've noted in my clinical experience is that putting in cold fluid in the belly also causes cramps and pain, and that can be dealt with by warming the dialysate. Drain pain is something very common in early on in PD education, and the way to deal with it is to slow down the flow of the fluid when you're draining, or put them on tidal PD, and that can only be done on APD. But another way to do that, if your patient is on CAPD and they have good residual renal function, is to tell them, once the pain starts and it gets a little more to tolerate, then just go to the other exchange. Let a little bit of fluid remain inside the belly. It impairs your clearance a little bit, but since they have residual renal function, you're not too worried about volume overload, and you can add a little bit of diuretics to take care of that extra volume overload if it happens. Next are hernias. They can occur in many places. As you know, the reason is weakness of the abdominal wall, and because of continuous raised intra-abdominal pressure, we can get umbilical hernias, para-incisional hernias, inguinal hernias can happen. Sometimes they develop slowly over a period of time, and sometimes they can follow quickly after any sneezing episode or coughing episode as well. Um, the most common complications to worry about are bowel incarceration, incomplete drainage, or patient discomfort because of the change in the anatomy. The treatment, you certainly don't have to put them on hemodialysis, and that should be the last resort, I think. You can opt for a low volume supine PD if they have significant residual renal function. You don't have to put them on CAPD. You can switch them to nocturnal PD on APD, or you can transition them to hemodialysis temporarily, do a surgical repair, and then put them back on peritoneal dialysis. Okay, so that's that. Another thing that happens mostly in the early period of PD initiation is pericatheter leak. That's because there is poor healing, especially in patients who are malnourished. Sometimes, when you put the catheter in, let the wounds heal for 2 weeks or 3 weeks, and then you start PD, slowly you'll start to see signs that the patient does not have good UF, or there is a slight bulge over the tunnel. There's a boggy feeling over the tunnel, and there is oozing of fluid from the exit site. So the treatment is give them a break from PD if that's a possibility, if the patient has good residual renal function, and wait for the healing to occur. There can be a surgical repair as well. Um, but mostly giving a break, waiting for them to heal, does the trick. Sometimes, rarely, if they have bad coughing spell, it can happen later on as well that you get a pericatheter leak, but it's mostly in the early part. Genital swelling, again, similar pathophysiology. That happens if there is a patent processus vaginalis, can occur as a swelling of the mons pubis in the females, as a scrotal swelling in the males. Can present as just weight gain and decreased UF. The diagnosis is you can do a CT with IP contrast to find where the track is. This is a picture of my patient who had scrotal edema after he sneezed. That's what he said. And when we did the ultrasound, there was a fluid inside the right side. So it was clear, and we did not go ahead with CT with IP contrast. But in cases where you cannot give IV contrast, IP contrast, you could do an MRI. You don't need to put a contrast for that. The treatment of this, if you want to continue with PD, is to do a surgical repair and then put them back on PD. Or the other thing would be to switch them to hemodialysis. Hydrothorax is happens once the patient is started on peritoneal dialysis and they have some rent in their diaphragm, whether they have a large hiatal hernia or usually it's on the right side. You get a hydrothorax that manifests as decrease in UF, progressive shortness of breath, and weight gain. On chest X-ray, you'll see pleural effusion, and on examination of the pleural fluid, there is a high glucose concentration. So The way to treat it is to give them a break from PD. That is one way, and because of inflammatory reaction to the dialysis, there is pleurodesis that happens. You can also do, if the patient has significant residual renal function, you could just do very low volume upright PD. Don't put them on supine PD, and still the hydrothorax will resolve. The other thing would be to do a pleurodesis that can be done laparoscopically, through a thoracoscope, or it can be an open surgery. Or the last resort would be to put them on hemodialysis. So we had this elderly gentleman who developed this complication, and we tried to do a pleurodesis, but it failed. And because of the pain associated with the process, he didn't want to undergo the pleurodesis again, and he shifted to hemodialysis. Um, Another alarming complication of peritoneal dialysis is hemoperitoneum. Um, the picture is self-explanatory, um, and the most common cause is menstruation or mid-cycle bleeding that happens with ovulation, and there is a blood-tinged effluent. Sometimes with aggressive physical exercise, you can or trauma, you can get blood-tinged effluent as well. The lesser common, but more worrisome reasons could be bowel ischemia, pancreatitis, EPS, a malignancy, a ruptured ovarian or renal cyst, or any coagulopathy. Hemoperitoneum should be, the patients, like young females, should especially be educated about this, because it is very scary to look at, and you have to tell them to take care of this early on, so there is no blockade of the catheter. The best way to deal with the hemoperitoneum is to do quick flushes. Usually using 2 or 3 bags does the trick, and the fluid becomes clear. If the patient is not taking heparin intraperitoneally, tell them to start adding heparin to the PD bags, so that fibrin clots don't form, and the catheter is not blocked with blood clots. And treat the cause. If the patient has abdominal pain, something to worry about would be pancreatitis in a young patient or in an elderly person. Like we had one patient who we thought had peritonitis, just plain simple, PD related peritonitis, happened to have a perforated duodenal ulcer. Another patient of ours who had hemoperitoneum. Initially, I thought that she was having it with her menstruation, which she always did, but then the pain started to get worse, and ultimately, we diagnosed that she had peritonitis. And not to stop PD, that it would be my point. Just because the patient is having hemoperitoneum, rather you should continue peritoneal dialysis and do frequent flushes, so that the blood does not form a film on the peritoneum and damage the membrane. Chylperitoneum, something very fancy. I've never seen it myself, but it's something we should always know about. It's usually caused by obstruction of the lymphatics from malignancy, from trauma, or from certain parasitic infections. And you get a white looking, milky looking effluent. And the way to diagnose it would be on lymphangiography and lymph scintigraphy. The effluent routine examination will have high triglyceride levels, which is not done routinely, so you have to test for that. Another way to check for it is to make the patient lie supine for at least 30 minutes, and then do a CT and because the lipid is lighter, it goes up and forms a layer on top of the effluent, and that can be differentiated on a CT. Treatment is surgery and treat the cause. Um, so catheter blockade is very common. We come across that a lot. There are many reasons for it. The most common reason is constipation. The side holes of the catheter get blocked as the gut gets distended. Another reason is omental wrap that can happen, and the catheter can be blocked by a fibrin clot or by a blood clot, and the catheter can sometimes become kinked. The easiest way to diagnose whether the catheter is blocked or not is to do a push and pull maneuver. If you can push fluid through, it means that the obstruction is outside and there is a ball valve mechanism. The catheter might be against the wall of the gut or the abdominal wall, and that's the reason it's getting blocked. Initially, when the omental wrap happens, there is inflow but there's no outflow. You can push fluid in, but you cannot pull it out. In If there is a clot inside the catheter, you can sometimes dislodge it with pushing fluid by filling the catheter with a heparin lock, and then after giving it a rest for 2 hours, then try to push and pull, and sometimes you can dislodge the fibrin or a blood clot. In terms of kink, you will feel a resistance in push and pull both. Do an abdominal x-ray that will give you an idea of where the catheter is. Sometimes you can see a kink, or malpositioned catheter, and it gives you an idea about the constipation status as well. And these are a few examples as I talked about. So the treatment is first thing to try is always try to give them laxatives, make them purge. Sometimes that moves the catheter and removes the blockade. Puts the catheter in the deeper pelvis, removes the kink. The other thing to do would be you can pass a guide wire and try to position the catheter. If it is malpositioned, or if there is a temporary blockade, you can remove that clot as well. That can be done fluoroscopically, or the other thing can be done is do a laparoscopic manipulation. Um, Something that was done at my training center in US, they used to put a TPA in if we thought that there was a fibrin clot or a blood clot. The way to do it is to put 4 milligrams of a TPA into the catheter and wait for 2 hours and try to push and pull again. So my personal experience in Pakistan, early on we had a lot of like 3 patients who had a mental block, and that was, to me, seemed a lot. And then we realized the reason was that the surgeon was placing the catheter a little bit higher up. So um, that we took care of that by discussing it with the surgeon, and he adjusted his technique. um, but after that we haven't had a single mental wrap. So I think it was technique related. So one of the complications that I worry about myself is EPS. Uh, um, it's a it's an inflammatory reaction to the glucose content of the dialysate, and because of the glucose degradation products in the fluid, that results in neoangiogenesis, fibrosis, mesothelial proliferation, and results in a dense capsule around the gut. It's very painful. The patients, I think I've seen two patients so far in my career, and it's a very painful, debilitating condition for the patient. And they get bowel obstruction symptoms off and on, chronic pain, intermittent pain, and blood in the effluent, like hemoperitoneum, off and on. Um, it's The risk factor for it is uh, time on dialysis. So there was a study that showed that the risk of EPS increases as your time on peritoneal dialysis increases, and it goes up to about 5% after 8 years. So, but patients who were on PD for 15 years also had a risk of 5 to 6%. But in patients who were on PD for about 3 years, the risk was less than 1%. And another risk factor is the dialysate concentration. So if you're using higher glucose concentration, there is an increased incidence of ending up with EPS. CNIs also have been postulated to be one of the reasons, because they are pro-fibrotic agents, and they cause more incidence of EPS. And since EPS is seen more in patients who go on to be transplanted after PT, it's seen more in them. Um, ARBs and ACE inhibitors are associated with a decreased risk of developing EPS. And the treatment is to decrease inflammation. You can give them prednisolone, 10 milligrams, or put them on tamoxifen as well. So these are the two things. Stopping PD if someone develops EPS is very controversial, because when the patient is doing peritoneal dialysis, they are actually the fibrin that is forming is being removed, and if heparin is also being added to the PD fluid, then there is effective clearance of the fibrin. So supposedly the disease progress is slow. If you stop PD, then the process of EPS doesn't stop. It rather it progresses more rapidly. And so switching them to hemodialysis for PD, for EPS, is not, I would say, the best choice if the patient has a poor membrane function, and that's why you're using higher glucose concentration, and that's why the patient is having EPS. Then and they don't have any good residual renal function, maybe you can put them on hemodialysis for those other factors as well. But having said that, it doesn't mean that you should not transplant a patient who has developed EPS while being on PD for a long time, because the survival of the patients who had EPS and that got transplanted was still better than remaining on PD or then switching on to hemodialysis. So, like I said, so that was it. Any questions or comments?
Thank you very much, Dr. Kiran. That was fantastic. I just have there's two things. One is that for the first lecture, as Dr. Bagman says, there's no patient of dialysis who cannot be put on peritoneal dialysis. And Dr. John Crabtree, who's a big famous name in access, peritoneal dialysis access, suggests that any patient on peritoneal dialysis who has a complication that, and I don't think there is any complication that cannot be treated and the patient can be put back on peritoneal dialysis. But these things, I'll just ask two comments quick comments from Dr. Mohsen first, and then Dr. Murtaza Cheema. And before that, I would like to welcome Dr. Fateh Shahzad. He's, I think, past president of APNA and Kemkana, and Dr. Khalid Mahmood who is an eminent nephrologist from Dallas. And then our local nephrologist Dr. Ghulam Abbas, Dr. Poonam, and Dr. Javeria from Karachi, and Dr. Batul from Fauji Foundation Hospital, Pindi. Welcome all. So over to you, Dr. Mohsen, please. Dr. Mohsen, you are not unmuted.
So now you can hear me?
Yes, please.
Okay, thank you, sir. So first, I would like to say that Dr. Kiran has very beautifully emphasized all the mechanical complications regarding the peritoneal dialysis. So I think we have seen almost all the complications except the EPS and the chylus in the peritoneal fluid. So all the as you said previously, that all the complications can be managed, and if you go step by step as per recommendations, you can easily figure out what are we dealing with. So considering the a mental rap is, I think this is the most problematic thing that we have ever faced. So this is the only thing that you have to go laparoscopic and remove the do a mentopexy, or you can have to readjust the catheter in the pelvic deep pelvis. And secondly, the patients, the another thing that I want to add here as a continuation of the lecture from the Dr. Irfan, that we are regularly doing urgent start peritoneal dialysis in our patients. So we usually don't give a dry period of the 2 weeks. We right away start the peritoneal dialysis in the patient. At the currently, I still have a patient admitted with me, and I am doing started her on urgent start peritoneal dialysis, and she responded, alhamdulillah. So this is the thing that we are already doing very good. So the only problem that we faced during the last few months was the supplies from the Fresenius that slowed down our take up of the peritoneal dialysis patients. I remember in the start of this 2023, there was a rapid increase in the patient take up in the peritoneal dialysis, and then we had to limit it just because of the non-availability of the supplies. So if the supplies are available now, the patients have more and more awareness regarding the peritoneal dialysis, and I find many patients who come themselves and ask regarding the peritoneal dialysis. They want to know how it works and how it is different from the hemodialysis and if it is better. Especially the quality of life in the peritoneal dialysis and the things that you can continue your job and your all the studies with this modality is a very attractive part of this modality of the renal replacement therapy. So this is a few comments from my side. So once again, really grateful for arranging. I'm thankful to you for arranging this webinar and the time taken out from the busy schedule by Dr. Kiran and Dr. Irfan. Thank you, everyone.
Thank you very much, Dr. Mohsen. I would like to ask Dr. Mudassir, can you please have your comments, quick comments, please? Thank you. You can unmute yourself.
Thank you. Really grateful to.
Yes, okay.
I hope you can hear me, sir. Thank you very much, sir. I want to thank Dr. Kiran and Dr. Irfan for a great talk on peritoneal dialysis. And I have been working for last six years in a public sector hospital, even for hemodialysis. In peritoneal dialysis, Dr. Kiran rightly mentioned that it's a great struggle, and I'm glad to hear that she has managed to around 100 patients on peritoneal dialysis in Islamabad. That's a great achievement. And in a public sector hospital, we are trying to establish an indoor facility for peritoneal dialysis. We plan to train nursing staff along with a bunch of doctors and dialysis technicians who can train and guide patients to start their peritoneal dialysis in centers and later on convert them to CAPD, and then they can get the benefit or the survival benefit that CAPD offers to them. So I'm really grateful, Professor Aman, to you and PD Society Pakistan for giving us the opportunity. And allowing us to receive this knowledge from great presenters like Dr. Kiran and Dr. Irfan. I'm really grateful.
Thank you very much. Any questions from the audience? Dr. Irfan and Dr. Kiran are here.
Yes, sir. Sir, there are a couple of questions in the chat box, please.
Gigi, please. Can you just mention them?
Right, sir. So the first one is from Dr. Butt. He says that he's from FFH and they have many patients
Dr. Batul, but she's...
Yes, sir. And they have many patients who can't afford their treatment, so they would be interested in a workshop, sir.
Sure.
And Dr. Javeria Chuftai has a question that what is the long-term prognosis of hernia repair in CAPD patients in terms of recurrence of hernia and peritonitis rate?
Over to you, Dr. Kiran.
Okay, I'll take the first question. So, Dr. Batul Bhatt, I'm very happy that we have a few people in Islamabad and Pindi who are actually want to do peritoneal dialysis, and it's going to be a joint effort. I feel sometimes limited because I work in a private hospital that caters to a very small population of and that's why we cannot give the benefit of PD to the patients who actually will benefit, young patients with good residual renal function who actually are working full time sometimes. So definitely I'm going to work on this and I'll try to arrange a workshop. If we have PSN in February and they have a workshop there, then probably I'll try to do something in March or maybe April, so that
Sorry, let me add here, Dr. Irfan, do you want to mention your trip to Islamabad in December?
Thanks, Dr. Kiran, for your comments. Two things. I think I appreciate your Dr. Kiran's comment regarding Islamabad, but in Lahore we are having a symposium on peritoneal dialysis on December 14th. It'll be live at Clearwood University. Plus, we'll have virtual capability for the audience to attend on it. What we are doing during the symposium, we are presenting the entire curriculum of peritoneal dialysis, some basics, some complications, and will also discuss the logistics in Pakistan, where we are and where we're heading. And that didactic session will be followed by hands-on workshop. So those who are interested in exploring peritoneal dialysis more and learning more about it, that's free for all. You can come and you can attend. I think there would be online registration as well. So try to register on it and come out or attend, and I think it's going to be good research. The second thing is peritoneal dialysis after hernia repair. It depends on the expertise of the surgeon who's doing the hernia repair. But typically what we've done is if somebody had a hernia, and if their body surface area permits us, and if they have good renal function, we typically put them on APD at night. We keep them dry during the day. And personally, I mean, in my experience of 24 years treating over 1,000 PD patients, I've not seen a lot of recurrence of hernia after repair. So I think it can be repaired and patient can be started back on PD, and down the road it's not an issue. So that should not be deterrent for anybody for converting them to hemodialysis.
So there is another question. What's the dose of streptokinase in PD catheter blockage?
Well. That we have tried it, doesn't work. So don't even go there. So just let me two comments on it. If there's a kink in the catheter, don't try to manipulate it. It's a lifeline. If the manipulation is not going to work, they keep on writing. Just go and get the catheter changed. I mean, it's much easier to get it changed. I mean, otherwise you are going to struggling with it for a long period of time. So second thing is that if there's a blockage within the catheter, and we see that there's a film inside which we're going to break with a with the urokinase, streptokinase, it's theoretical. In clinical practice, I've tried all that those things don't work.
Thank you, sir. There are a couple of more questions. The first one is that what about hernia repair with mesh? Is PD an option with that?
Yeah, that's okay. I mean, we've done at times with mesh. There's some theoretical concerns that some people say that, I mean, if they get peritonitis, the mesh can get infected. Personally, in the patients who hasn't had, it depends what your peritonitis rates are. Our unit stands at 1 episode every 60 to 70 months, which is one of the better units. In the United States, it's 1 episode every 36 months is an average. If you have a patient who had a track record of 2 years, for example, I'm just quoting an example, haven't had infections, I wouldn't have any reservations with that. But there's some theoretical concern that if you do the hernia repair with a mesh, I mean, sometimes it can get infected. I've never seen it. I like others, like Dr. Nov'23 or Dr. Kiran, to comment if they've seen any infected mesh or not. I've not. So I would not have any reservation of doing a hernia repair with a mesh.
Yes, I had few patients who had undergone hernia repair with mesh, or they had a mesh before and then they had to get the PD catheter in. So in both the cases, we had no issues. The patient who required peritoneal dialysis, who was on peritoneal dialysis, required a hernia repair. We just did like quick exchanges 1 or 2 days early, and then just put the patient on, got the surgery done, and then we gave the patient off for another couple of days because the patient had a good residual function and it went well. We didn't have to stop the dialysis afterwards or switch to hemodialysis. Dr. Kiran, any comments?
I was going to ask how long did you keep them off peritoneal dialysis, but you answered it already. So,
Yeah, typically, just a common sense thing. What we do is, I think it takes 2 to 3 days for the pain to settle down. Well, I tend to dial them aggressively for like 3 to 4 days prior to,
before. Yeah.
and especially if they don't have any kidney function, and then just don't do any dialysis for 2 to 3 days. On the third day, most likely, I'll start with low volume exchanges, advance it every 2 weeks to the full volume by 6 weeks.
There are some more questions, please. One is hand raised, and another one, I think, sir, Nov'23, it's for you, sir. Is there an update on PD therapy approved on Sehat Sahulat card?
Well, and we had the PD on Sehat Sahulat card in Punjab, but that started well. It was supposed to be expanded to the other hospitals, but due to some reasons, it was not carried forward. But we are hopeful in the future. It will be a significant part of the healthcare provision by the government, since I think a lot of the government hospitals are requiring that peritoneal dialysis should be available at the centers, and this is going to push it into the Sehat card, inshallah.
We have a raised hand from Dr. Abdul Rahman. Dr. Abdul Rahman, please ask your question.
Yes, please.
Thank you for letting me ask the question. My question is that just like dear doctor just said that like in the next month there will be a hands-on workshop. So what do you think that for us nephrologists who are already practicing nephrology, will that hands-on workshop be enough for us to start PD in our setups, or we'll still have to go some sort of training before we'll be able to do that? And my second question is that is there any setup in Pakistan, Islamabad, Lahore, or Karachi, where or one of our esteemed nephrologists is providing hands-on training for those of us who can actually travel and take a break of like 15-20 days to get such a training and get back to our workplaces and start PD?
I personally think that that lecture is enough if you've already trained nephrologists. That information is enough to initiate peritoneal dialysis on your own. I mean, any time you're starting a new modality, it's always wise to maybe a little smart about it. Maybe try to start just optimal patients who are optimum candidate for PD. Do not start any marginal patients. And as your experience will grow, your comfort level will grow. And then the thing is, anybody from Pakistan, I mean, I'm at a phone call away. So, and if there are any questions anywhere, I'll be available. I'm sure Dr. Nov'23 is a great, excellent resource there. So we are always there for you. If you're uncomfortable with anything, you would like to discuss anything, you can reach out and you can discuss.
Absolutely. You know, we had many issues and we talked, we called, you know, the many nephrologists in USA, including Dr. Irfan Manir, and they're all very helpful. We have Dr. Ahad Qiyum here, Dr. Kiran, and Dr. Javeria, Dr. Salman Imtiaz from Karachi. So there are a lot of people here, you know, who can support and, you know, don't shy of calling anybody anytime. We have good nurses and technicians who are well versed with the patient issues and who can be approached very easily also. And this is all under the umbrella of PSN and PD Academy of Pakistan.
There's one more question in chat box. It's for you, Sir Irfan Munir, and that why there isn't much increase in patients of PD in USA despite of all facilities.
Just probably, I think biggest issue is comfort level of the nephrologist in practice. My personal practice, my penetrance of peritoneal dialysis is about 30-35%. So in United States, the model which always works is just start involving the economics of the modality. I mean, what government has done at this point is like there's an incentive of financial incentive of doing peritoneal dialysis. Plus, there's a disincentive if you're not doing home dialysis. Plus, I mean, your patients do better with home modalities, whether it's peritoneal or home hemo. I mean, they just do better with it. So I think it's gradually the nephrology community is trying to understand and realize that that may be the way forward, and they're starting more and more patients on peritoneal dialysis. And it's a more upfront work, as I mentioned in the beginning. I mean, just starting peritoneal dialysis or starting a peritoneal dialysis just does not mean that you need to train one nurse and one technician and you'll have a good viable peritoneal dialysis program. I think as I initiated my discussion that the infrastructure, a good infrastructure is the key to success. But infrastructure, I mean that you have to have nurse champions, you have to have technician champions, and you have to have one or two nurses who are champions in peritoneal dialysis, who believe in it and who want to preach it and you want to carry it forward. And you have to have one or two champion technicians who believe in it and who have good skill set and want to learn it and want to carry it forward. And then the nephrologists who are champion, who believe in it, who think it's going to work. And once you have that belief that that things are going to grow, and in USA, I mean, just the resistance and the lack of growth has been just the poor training to the nephrologist at the time of their fellowship, and then not having a comfort level with initiating peritoneal dialysis, and then subsequently the ease in which the dialysis facilities or people who are running the most of the dialysis companies, they become so convenient to initiate somebody on hemodialysis because of some fiscal benefits that just you place a central line with a one call and you refer the patient to them and the treatment is going to be started. So it's multifactorial, but mostly I think it's the comfort level of the nephrologist and believing in the modality of the treatment are the two keys.
Right, sir. Please.
I think I'll have to ask Dr. Azarwaid. He wanted to ask some question or comment. Dr. Azarwaid, you can unmute yourself.
Thank you very much, sir. Can you hear me?
Yes, yes, please.
Yeah, thank you very much. It was an excellent seminar. I really enjoyed it, and especially the known infectious complications that was covered very comprehensively. I was just writing in the comments box as well that I feel that there are two sort of bottlenecks or where we need to be more aware in establishing a low clearance clinic so we can streamline our patients towards peritoneal dialysis. Because some patients who crash landed, they probably, so most of the time, they don't have an access to a center where a PD catheter can be put in. So one thing is that. The other thing is that can we arrange some, I'm not sure whether we've already done so, arrange a workshop which is a hands-on a PD catheter insertion workshop on mannequins. You remember we used to have such courses in UK. I'm not sure how much cost effective it's going to be, but definitely it will be a great help for our junior nephrologists to get used to or feel comfortable in attending this course or getting more training in terms of PD catheter insertion. And the third thing you've already answered that most of our patients who are on hemodialysis, most of the centers or most of the time the hemodialysis is on a charity or on a Sehat card. So the cost is an issue as well when you discuss with the patient, because most of our dialysis patients belong to that socioeconomic group where they cannot afford so many thousands a month for a PD fluid or a PD peritoneal dialysis to be their first choice.
Thank you very much, Dr. Azhar. I think you're right. We have already, we had a workshop in 2019 under PSN, where a lot of people came from UK, even USA, and Nepal. And we had a workshop where we had a hands-on training on, self-made boxes with some membrane on it to put a catheters. It was very useful. And then we had recently again in Karachi doing the same thing. So this is quite possible, and this is being done. But as Dr. Irfan suggested, that when you start a PD program, so don't go into the areas where you're not totally confident. So you have to have a surgeon. So let the surgeon put in the catheters. You learn your PD catheters along with some other interventional nephrologists. And when you are, well versed with it, then you can start your own PD catheter placements. And that is going to be the success of the program, I think. There was one question here about the local production of PD by Dr. Mudassir. We are on it, and one of the company is ready to roll out some of the PD catheters, CAPD catheters, CAPD kits, and we'll be able to probably see some definite answer in about 3 to 6 months, inshallah. I think if there are not any more questions.
So there's one question about the cost of CAPD3 exchanges in Pakistan, sir.
So 3 exchanges, we're just calculating. So one bag costs like 420 rupees, and the cap, one mini cap costs somewhere around 340 rupees. So one exchange costs somewhere around 700 about 70 or 80 rupees. So this is for one exchange. So you can multiply by 3 or 4 as you want to do the exchange. So this is some of the patients, if you start early, urgent start or early start with a residual renal function, you can do like once a week dialysis or twice a week. We have many patients. Dr. Ahad Qayyum has many patients. Even Dr. Salman has patients in Karachi. I'm sure Dr. Kiran has few patients who are also going PD for once or twice a week or something like that. So this is something which is quite possible. So I think with this, I'll wrap it up because we are already almost 20 minutes beyond time. Thank you very much, Dr. Kiran, Dr. Irfan Munir, for your time that you took because it's a morning time over there and you had to come in between your patients to take this webinar. Thank you so much, everyone, for participating and asking questions. Thank you so much. Assalamu alaikum. Allah Hafiz. Allah Hafiz.